I believe it is very nearly 6 o'clock here, 4 o'clock in San Francisco, 8 o'clock on the East Coast. And tonight we're going to be talking about bladder reconstruction, which is, as you know, a very broad category. Oh, by the way, I'm Elizabeth Yerkes from Lurie in Chicago. This is a really broad topic, obviously not something that we can fit into 45 minutes if we cover every aspect of it. And so I've chosen select aspects of it. The title, Intentional Bladder Reconstruction, is just to remind us to be mindful in all aspects of what we're doing. So sit back and let's do this. So when we're talking about being intentional, we need to be present in all aspects of the preparation and the case, but doing reconstruction is something sometimes that can get into your head. And so hopefully this will help you keep your head. So I have no financial disclosures that are relevant to this or to any other topics. This talk is meant to be for fellows and is therefore practical and will have limited citations, although there are some. The thoughts represented here are my practice, at least currently, and we all know that what we do can change over time, and this is the confluence of 3 decades, which was hard for me to look at 4 different institutions, and there's been some joy, sweat, and tears associated with this. I'm fluent in moderately to maximally invasive surgery and conversant in MIS, but today we're talking about open surgery. So on the agenda today is why bladder reconstruction is not for the faint of heart. We're going to talk about bladder augmentation primarily, but it'll be interspersed with other related reconstruction tidbits. We'll do a deeper dive into complications and then have a few parting words. In terms of augment, we're going to talk about getting there with the patient, being there, and taking care afterwards. So first, I think everybody who's done a reconstructive case, and most importantly, taking care of it afterwards, we know that these can sometimes not be for the faint of heart. It's extremely time consumptive, both beforehand, during, and most importantly after, as you're with this family for a lifetime. The patient and family is something like a marriage, and that you have to be completely committed to the care of these kids. There's a lot that's going on there in the operating room, lots of tubes and drains and lots of people involved that we have to take care of. And because it's an extensive procedure, certainly there's going to be some surgeon fatigue associated with that. And then when we layer onto that the fact that some of these patients will have a shunt and the effect that it has on their bowel wall and mesentery, they'll have scoliosis and contractures, they may have bacteriuria that we need to treat ahead of time, they may have chronic kidney disease, and we have to be mindful of, first of all, the decisions that we make for them for their reconstructive procedure, but also how we care for them afterwards. And they may have had prior abdominal surgery, and all of these can increase the likelihood of complications. In terms of complications, I think of them as occurring on a spectrum, from annoying and frustrating to dreadful and things that make you want to quit. But for some reason, we keep coming back because we feel like we're doing something to help these kids. Unfortunately, most of the complications occur on the annoying and frustrating spectrum rather than on the other end. And I think it's helpful to help families understand what they're getting into by letting them know that something's going to happen. It may be something very minor like a tube malfunction or having a tube dislodge or a urinary infection, but there are some really significant potential complications as well. So there's a laundry list of things that we need to go through with the family, and I won't go through them all here. But one important thing to also tell them is because of the complexity of the patient and the complexity of these procedures, there's the potential that they're going to have further procedures despite this initial expensive one. I have to give some of my early credit to what I know about reconstruction to the team at Riley, with whom I did a lot of reconstructive procedures, and it's that team who published this work looking at the need for additional bladder surgery after bladder augmentation in children. And this wasn't necessarily re-augmentation, but had to do with stones and bladder complications and channel complications, basically any trip back to the OR. And what they showed is of those undergoing bladder augmentation, just over a third will need further bladder surgery after augmentation, and less than 15% will need revision of the channel. Still, these numbers are not insignificant. So let's move into bladder augmentation specifically. How are we going to get there with our patient? Well, what are the objectives of bladder reconstruction? There are several, and each patient is a little different in terms of what we're hoping to achieve. And we want to be certain that we know exactly what they need and that the family knows what they're getting. So the objectives include protecting the upper urinary tract, improving or securing continence, enhancing independence and self-competence with their care in terms of the bladder and bowel program, simplifying care for the caregiver and protecting modesty. Even if the patient may not be able to catheterize themselves, we can have a more private way to catheterize, or we may be preparing the bladder for renal transplantation. So here's a child who's in need of your attention. And so we're going to look at all the data that we have, both urodynamic data, the clinical data, their continence pattern, their upper tracts, and try to form the right potential operation for the family. But again, then the family has to have an understanding of what they're undertaking, and ultimately they would make the decision about what feels right for them at this time. So it's very important that we have a mutual dialogue and make things very clear. So on urodynamics, sometimes we're identifying that there are high storage pressures, which may lead us toward bladder augmentation, or on the image on the prior page, we can see that the bladder neck is open. So there's a lot of information we can put together in terms of crafting the right operation. So there are a variety of procedures that go along with these needs: bladder augmentation, a continent catheterizable channel, which comes in several flavors: Mitrophanol, Monty, Spiral Monty, continent vesicostomy, the Malone antegrade continence enema for bowel continence, a variety of bladder outlet procedures, and ureteral reimplantation may or may not be undertaken at the time of reconstruction. Each case is different. You have to remember that with each of these, there comes that same laundry list of complications that we discussed. And again, this is not insignificant, and the family needs to be fully aware. So let's talk about being there and performing bladder augmentation. We're in the operating room. We've arrived at this important decision together. We've counseled and prepared the family and child for what to expect. So what are you going to do now? Intraoperatively, I would strongly encourage you to get very involved from the beginning with positioning the patient and discussing with the team, the anesthesia team, and the OR team about what's planned and what special considerations there may be for this child. Together, we want to avoid positioning injury. We want to avoid incorrect counts. We want to avoid the shunt being harmed by the procedure, avoid hypothermia and fluid overload due to the effect that it'll have on the bowels and healing, and avoid thromboembolism in the age-appropriate situation. We want to put these patients in a neutral position, which I think is an oxymoron given what we're going to do to them, but it's particularly important that their arms are in neutral position because these patients really need their arms. And if they have any sort of stretch injury at the shoulder or wake up with pain in their arms from their arms being hyperextended, we really haven't set them off on the right foot after surgery. In terms of their spine and lower body, each child's going to have a unique shape, and there may be areas that we need to support in terms of in order to relieve pressure on the spine, or there may be bony areas on the hip or the sacrum that we need to provide extra padding for to minimize pressure sores. We want to keep their legs and hips as neutral as possible during the operating room, and of course we want to maximize our surgical space. And so sometimes when patients have contractures, this can be a real challenge for us. We have to be, in consideration of the positioning, we want to be aware that patients may get a pressure sore during the course of the operation, and we always want to check the skin at the end of the procedure and on each day postoperatively. And also we want to remind the anesthesiologist that during a long case, it's also possible that we would face alopecia or risk for alopecia. So here we use gel pads, gel rolls, heel boots, or fillers if there's an area underneath the spine where there's a gap. We want to keep all dependent skin dry. My team gets under the drapes and massages the heels during the case, and I ask the anesthesia team to turn the head and massage the scalp every few hours. It takes a village in terms of getting these patients positioned. Again, they each have a unique body shape and contractures, and this young man had some significant contractures at the hip where we couldn't straighten his legs any more than this. And this was the initial position that he was placed in, and it became very clear that we would, that the legs would be in our way in terms of our operative space. So together we positioned the patient differently in lithotomy where his hips were still in what was his neutral position. By doing this in a bit of Trendelenburg, we were able to expand our surgical field. So we want to make sure that that the urethra is accessible for placing the catheter. We want to make sure that we've got the sequential compression devices when appropriate for the patient. We've got the 1000 drape here, which will help keep him dry. And there's a thick gel mattress that's been placed in the lordosis to support that area. A word also about the enhanced recovery after surgery principles. The goals of this are to have early return of bowel function and earlier return to their usual state of health. No special bowel prep is performed, and the patients are fed early on the day of surgery or day after. Preoperative and intraoperative highlights for those who aren't yet familiar include, again, no bowel prep, regular diet the day before surgery, and a carbohydrate load 2 hours prior to surgery. Maintaining euthermia throughout the case. This will involve having warm blankets in the holding area and during the prep, as well as a bear hugger. And euvolemia, where the anesthesia team very carefully controls things to make a difference with the edema of the bowels and also with the soft tissues. Is ERIS safe in children? Well, this is being pursued currently. We have to thank Kyle Rove for his leadership in this multi-institutional study to learn who and how this can be used in children. So what are the steps of ileoinguinal cystoplasty? I know that many fellows don't get the opportunity to do as many augmentations as they may like, and quite honestly, I'm not sure that you could do too many augmentations. I think it's difficult to come out and feel completely comfortable. And it would be very typical to be mentored by another surgeon when you come out into practice. So let's talk about the steps and how these steps interface with other concomitant procedures that may be part of the reconstructive procedure that's planned for these patients. So let's get in first. You need to have a plan. We need to know exactly which procedures we plan for our patients, and therefore considering the procedure plan and considering their body type and considering the expectations of the family, what incision would be most reasonable. Typically for these open procedures, it'll be a lower midline incision. If possible, I like to stay below the umbilicus, but make a plan to come up just to the left of the umbilicus, midway up. A broad fan and steel incision is another option with large suprafascial flaps, subcutaneous flaps, and then a vertical incision in the fascia. And this can provide comparable exposure, but I would be very careful about this in someone who has a thick abdominal wall, as this increases their risk for seroma or infection even if you drain them. When we form our plan of what order the cases or the procedures are going to be done, we want to think of it as this body is having two different compartments that we're working across. And so we want to start in one compartment, complete what work is necessary, move to another compartment, and then back to the original compartment to put everything together. We want to be mindful in choosing the steps of our procedure that the bladder wall is going to become edematous as soon as we open it, but it may become edematous even if we don't open it. And that there will be edema of the bowel wall as well. So we want to get the most important aspects of each, and most important aspects of the procedure that we're doing on each of these tissues. We want to get this done quickly as soon as we expose those tissues. We also want to be thinking, quite frankly, if there's what we can do to screw up during the procedure. So that seems a little bit negative, but if you know what you need to do, but are always thinking about how things could be messed up, then we're likely to be happier with the result in the end. And so, for example, we want to make sure that we put in the suprapubic tube before we finish closing the augmentation, because we spent a long time closing the aug, and to leave that out would be an egregious mistake. Likewise, we want to check and make sure that our appendix is going to be suitable for the continent catheterizable channel prior to harvesting the bowel for the augmentation, because we don't want to come back and redo the bowel anastomosis when we find out that we need to cut a Monty. So again, we have to have a plan, but it seems silly, but you have to be flexible as well, because you never know quite what you're going to find in there in terms of your resources and the patient's body shape. So again, there are a variety of procedures that we can choose from, and you are going to decide with the patient and family what procedures are appropriate for both the condition and appropriate for what they're ready to handle at this point. So again, we may have an augmentation, we may have a catheterizable channel. In terms of the channel, you need to have thought ahead. What are you projecting you're going to use for the channel? Are you going to have a mitrophanol and a MACE? Have they already had an appendectomy? You need to think about what the resources are so that you can talk with the families about what the options are. What are you going to do if you get in there and the appendix actually isn't there or is too small for you to use, or if it's not enough for a split appendix? Do you know how to make a Monty? You just need to have a backup plan, always during reconstruction. Again, the other procedures potentially are the MACE, a variety of different bladder outlet procedures, plus minus reimplant. So the reason I said you have to be flexible is that there's a bit of moving back and forth. And I know I said that we want to have it be compartmentalized. We've got the space of Betzius where the bladder is, and we're going to do our initial procedures there, and then we're going to move into the abdominal cavity where the intestines are exposed and more prone to edema, and where we're going to be potentially coming into contact with the BP shunt. But despite that compartmentalization, there is a bit of back and forth between the procedures. So initially, if there's going to be a bladder outlet procedure, we're going to do that first because we want to get in and get the delicate procedures in the floor of the bladder taken care of before there would be any edema of the bladder wall. Next, we're going to go into the abdomen, and we're going to do our initial reconnaissance of the appendix if there's going to be a continent catheterizable channel, and determine whether it's going to be suitable or not, so that we can then plan the rest of our bowel work. We're then going to move on to part 1 of bladder augmentation, which is going to be isolating the intestinal segment for the augmentation, doing our reanastomosis, and creating the patch for augmentation. But we're not ready to put that onto the bladder until we've done the tunnel for our continent channel, and then we can sew the augment on. At the end of the bladder outlet procedure, if there's going to be a bladder neck reconstruction and a sling, we would come back at the end of the procedure to wrap the sling around the bladder neck and tension the sling. And then the last thing we would do would be to mature the stomas at skin level. So you can see that there's a little bit of back and forth between the steps of augmentation and the steps of the channel, and even the steps of the bladder outlet procedure. But all are done for a reason. So let's talk about the steps of bladder augmentation. Again, this is something that you may or may not commonly do during fellowship, and I think it's just good to think through things stepwise. So first, we talked about the incision that we would use. As soon as we make the incision, we're going to get into the perivesical space. You'll often find that the bladder is very thickened and elongated and irregular, and the space generally dissects well around it, but if there's been a lot of inflammation, then perhaps this will take some time. Basically, we want to know that we have free access to the side walls of the bladder, but we're not necessarily trying to mobilize the bladder out of the pelvis. And we're going to open the bladder if we're doing a bladder neck reconstruction and complete the work on the bladder floor, whether it's a bladder neck reconstruction or reimplants or both. And then we're going to go into the abdomen. If the patient has a shunt, I would recommend that we find the shunt. I think there's 2 different viewpoints to that. One is don't look for it unless it shows itself, and the other is proactively look for it and isolate it. And I would favor the latter of those 2 approaches. And we'll talk about that a little bit more later in terms of the risk of complications for the shunt. Next, you're going to find the cecum, which sometimes can be quite high in these patients, depending upon their the length of their trunk. Those with a short trunk tend to have a higher cecum. We're going to make a decision regarding what resources we have for the continent catheterizable channel. Is the appendix suitable for the procedures or not? We're then going to preserve the distal or the terminal aspect of the ileum for its absorptive properties. We're going to then isolate our working segment, divide the bowel, and pass the working segment inferiorly toward the bladder. We need to, at this point, we need to have already thought about whether we're going to need a Monty, because we need to be harvesting the bowel for the Monty at the same time as we're harvesting the bowel for the augmentation. Here, a reminder, did you ask about handedness? I learned the hard way that it is very important to ask. A right-handed person can catheterize their umbilicus and can catheterize in the right lower quadrant, and maybe they can catheterize on the left side, but not very well. And you can really traumatize that channel and potentially lose it. Conversely, a patient who is left-handed can easily catheterize on the left and can catheterize through their umbilicus. And may or may not be able to catheterize well on the right successfully over the long term. It's doable, but awkward. So if we know ahead of time, the reason that's relevant is if you are going to cut a Monty for a right-handed person, the Monty would be the distal-most aspect of the bowel segment that you're harvesting. And if they're a left-handed person, it would be the proximal-most aspect of the bowel that you're harvesting. Now we're going to reconstitute the bowel. I prefer to do a hand-sewn anastomosis. We're going to close the mesenteric tract to prevent an internal hernia. We're going to detubularize the bowel patch and sew it into an inverted U, and then we're going to put everything together and get out of the OR safely. So we're going to show some pictures of the steps. A few words first. The reason that we're going to preserve the terminal ileum, and again, we want to preserve at least 15 centimeters, but it's fine to preserve more. And you may find that moving a little bit more upstream gives you a little more mobility of the mesentery. The reason we care about preserving the terminal ileum is that that's where B12 absorption happens, where bile salt absorption happens, where fat-soluble vitamin absorption happens, and B12 is a water-soluble vitamin, not a fat-soluble. And also keep in mind that if we take not only the terminal ileum, but the ileocecal valve, as may be done in certain types of reconstruction, we've created a rapid transit of the small bowel contents that may be bothersome to these patients. They may have steatorrhea in addition because of loss of bile salt absorption, and they may have poor anal sphincter tone by virtue of having myelomeningocele or a related condition. And so if you give them rapid transit of loose stools, you really haven't done them any favors. These are some interactive pictures. We were borrowing a VTOM camera one day in the operating room, and it took great pictures for us. So this is a piece of ileum. The suture at 12 o'clock has marked the first site of our division of the mesentery. Unfortunately, this patient, I know this patient did not have a VP shunt, and so what I see is that the bowel wall is very glistening. There's not any granularity or a thickened rind over it, as we sometimes see in patients with shunts. And I can see that she's a very slender patient because we essentially can see through the mesentery, which is always something that I'm grateful for. So we want to look at the branching arcade of the mesentery, and it's these more proximal vessels that we need to make sure we keep intact. But you can see here that there's multiple windows. And there certainly will be vessels that are sacrificed as you come across, but we want to make sure, again, that we're preserving this proximal aspect and that we'll have a nice vessel on each side wherever we divide the mesentery. So we're going to make some windows in the mesentery. The person who's making the windows and who's going to take down the mesentery has the best view. When there's a thicker mesentery, both surgeons are not necessarily able to see what's going on. But we're going to make windows. You can see we've got one made distally here, we're making another, and then the third is going to be here. So we're going to take the vessels across here and here. I prefer to use a bipolar to take this down. I actually learned that from Tony Casal at Riley, and I just find this to be something that is easier for me to tolerate than clamping and tying, and it's easier to watch someone do and know that we have reliable hemostasis. And there's no transmission to the surrounding tissues. So here we are finishing up taking down, this is going to be the last vessel that we take down here in the mesentery. There'll be some areas here that we need to clean up as well with a combination of bipolar and a fine forceps and a bit of electrocautery. What I wanted to illustrate here again is that proximal vessel that we need to keep intact, and the segment going this direction has this nice vessel as well as all the other vessels. And the segment that's going this direction will have all these nice vessels as well. So keeping the main vessels is the most important part. We're going to, at the level of each mesenteric window, and again, there's going to be two because we're isolating a bowel segment, we're going to clamp the bowel with atraumatic bowel clamps, and we're going to divide. And it's important to make sure that we have that we've cleaned off enough of an area that when we divide between the bowel clamps, there's a sufficient amount of bowel sticking out from the clamp so that the clamp doesn't come off and so that we have something to do our anastomosis. Here, we're getting ready to divide the bowel, or we've already divided the bowel at this area, and now we have a mesenteric window where we can make our other separation to get our working segment. So this picture would not make sense without an explanation, but this is one end of the bowel that's going to be reconstituted. At the top of the screen, the feet are at the bottom of the screen, so we're going to pass the working segment down, and then the bowel will be reconstituted above it. Okay. By using this configuration, we lessen the nature of an internal hernia, because if you have a bowel segment passing under the mesentery of your working segment, that by definition is already an internal hernia. And also this allows for the shortest course of the mesentery to the bladder to minimize the risk of there being tension on the mesentery. This is preparing for the anastomosis. These are the cut ends of the bowel. These are atraumatic clamps, and you can see here we're about to put a holding stitch here and here We're going to do the same on the other side in order to keep the bowel segments, give us something to hold on to and keep things lined up during the anastomosis. These sutures are not tied. I do a single layer partial thickness anastomosis with silk. The sutures are getting the seromuscular tissue and coming in just above the submucosa, which I have an illustration coming up, but here one stitch has already been placed and we're doing the second side of the next stitch. And this is the anastomosis in progress. This is an illustration with this checkered area being the seromuscular layer, this being the submucosal layer, which is a thin, it appears somewhat thick and it's very white layer. It appears very different from the seromuscular tissue or the bowel mucosa. The bowel mucosa sometimes can be a little bit friable or wrinkly, and we just always want to make sure that we look in and see the submucosal tissue. So our sutures are going to come in at essentially a right angle. We're going to come through the seromuscular tissue. We're going to come out in this plane. And we're going to go across to the other side, repeat, and come out in that correct layer. And then again, these are individual sutures, interrupted sutures. This is a completed anastomosis. And we always want to palpate our anastomosis to make sure it's patent. I like to liken this to a piece of calamari without tentacles. We want to make sure we close the mesenteric trap. I do this just closing the peritoneum on one side, not full thickness of the mesentery. And the purpose of this is, again, to reduce the risk of internal hernia. The working segment, again, was passed inferiorly. We want to irrigate it to make sure that we get all the bowel contents before we open it. And even in the era of not performing a bowel preparation and era style, having them have a carbohydrate load and a regular diet the day before, there tends to be very little actually within the intestine. The intestine is open on the antemesenteric border quickly using electric cautery. I like to use a disposable marker as the guide. And then we sew our inverted U patch. So the bowel has been folded on itself. So the bowel is open. These are the medial edges to form the U patch held in place by Alice clamps. And then it's a running absorbable suture. I use 3/0 Vicryl. This illustrates various ways that you could fold the bowel. I've never performed an augmentation with a segment folded in this nature. It's always been an inverted U. This is what the running anastomosis on the inside looks like. I'd have a little fun with this today for you. The way I bivalve the bladder, I learned in Indiana. Essentially it's a clamshell, so we want to open the bladder as widely as we can. But if you're doing a continent catheterizable channel, one modification would be that you come up the anterior wall, and as you get closer to the dome, you're going to veer off to the left side if you're putting the channel on the right. I had a hard time connecting here, but essentially you're going to go over the hill and come down the other side. So essentially you have a flap or a handle that makes that side of the bivalve a little more. This circle represents the Yerkes, and therefore when we've bivalved, the Yerkes is here, and I excise the Yerkes and bring the continent channel through that. So you have a little extra room to implant your channel, and it's a little more mobile to reach the sidewall of the body. So we want to bivalve widely. We want to do that in order to avoid any wasting or hourglass effect that may affect the dynamics of the bladder. We want to start our anastomosis posteriorly because you can't come back and sew the posterior part after you do the anterior part. As you're putting everything together, remember we have multiple procedures that we may be thinking about, so don't forget about reimplanting the channel because it gets first dibs in terms of where it goes, and don't forget about your suprapubic tube. This illustrates the suprapubic tube coming in through the abdominal wall and through the body wall. This was a special JP I was trying for a while, but currently I actually prefer to use a 19 French round lake drain. I found that they irrigate and drain very nicely throughout the duration, but you do have to make sure you secure them well. And this is the finished product. Sometimes the bladder augmentation initially looks a bit heart-shaped, and that's due to the mesentery coming in this area, but that all straightens out later. So next we need to get out safely, and then we have to keep taking care of the patient. So there's a lot of potential for error for the reasons that I cited, but there's also a different, another layer of potential error due to the number of times that the anesthesia changes and the number of times that the circulator and the scrub change. So with these multiple breaks, we need to make sure that there are very good serial counts, not only of sponges, but particularly of the needles, because a large number of needles are used on these cases. And there's nothing, well, there's a lot of things that could be worse, but it's really bad to get to the end of one of these long cases when you're tired and find out that the needle count is incorrect and that multiple people have left and are long gone before the case is over. At each step of the closure, once you close the bladder and then you're starting to close the abdominal wall, be sure to irrigate your tubes to make sure that nothing that you're doing is impeding tube function. And then you need to secure the tubes like your life depends upon it, or like your fellow's life depends upon it, or your resident, because that's really your lifeline for the next month or so. So in terms of taking care of bladder augmentation, we have to worry about both the short and long term. And as we talked about before, there's a laundry list of complications that go along with augmentation. And some of them can be just sort of annoying, and some of them can be quite heavy for both you and the patient. So in terms of complications, there are those that are general major abdominal complications. Again, any abdominal exploration is not insignificant. So we may have wound infection or hernia, you may have a catheter malfunction, a bowel obstruction or a leak, or you may have a shunt problem. And the shunt problem actually is something that's specific to augmentation as well, because it's not as big of a concern with just a routine abdominal procedure. In terms of complications over the longer term that are specific to augmentation, we have mucus and the need to deal with it, inadequate dynamics of the bladder, a hyperchloremic metabolic acidosis risk, a B12 deficiency, bladder stones, perforation of the bladder, and tumor. And I used to, back in the day, before we knew about tumors, I used to think that the worst thing to get to on the list was perforation, and perforation's pretty bad, but then we had to start talking about tumors too. But we'll try to put all of these in perspective. So first, for shunt malfunction, there were several, back when I was a fellow, we looked at the experience at Riley, and there were a couple of other papers in the literature, essentially with the risk ranging from 0 to 20%. In our series, we found that the risk of shunt malfunction related to augmentation was very low, less than 2%, as long as we took precautions. We, of course, don't know, because standard precautions were taken, we don't know what the risk would be without those precautions, but it feels better to take these simple steps. So upon entering the abdomen, when you encounter the shunt, we would isolate the shunt. So you would have some bacitracin irrigant, and a lap sponge and a couple of Raytex sponges. Use a sterile atraumatic forceps to grasp the shunt, not allowing it to touch the skin. Place it into the sponges, wrap all the sponges together, and pack the shunt into the upper abdomen with the tail hanging out of the abdomen so you can't forget about it. And you'll collect them again at the end of the case, again with the sterile forceps to push them into the upper abdomen. In the series, bowel preparation was universal. But bowel preparation is not currently practiced at all institutions, including this one. We have to be vigilant postoperatively. If I say that symptoms of a shunt malfunction may be headache, dizziness, confusion, nausea, and vomiting, well, those are all common postoperative complaints that people may have. And so we have to rely on the family to tell us what might be similar to their prior shunt malfunctions. And we need to involve neurosurgery promptly if there's any concerns or questions. So in terms of the augmentation-specific nuisances and complications that will plague us over time, mucus comes at the top of the list. So this is a universal issue after bladder augmentation, except for gastrocystoplasty. The mucus may decrease after early healing. I found that it's usually a sign that bowel function is returned when we start to see mucus in the early postoperative period, and the mucus tends to be the worst while the tubes are still in place, and over several years, some patients will have hardly any, and other patients will have quite a lot. Those who catheterize through their urethra are definitely in an advantage in terms of clearing mucus because it drains nicely by gravity through the urethral catheter as opposed to being siphoned out through the continent channel. That doesn't, however, give them the right to not irrigate because there are definitely benefits to irrigating even if they cath per urethra. The mucus is a nice place for bacteria to hide, and that increases the likelihood of there being odor associated with the urine and also increases the likelihood then of symptomatic infection. We recommend a daily mechanical irrigation. I usually do this twice a day in the early postoperative period for several weeks and then once a day thereafter. I can't say how compliant people are with that. I think it's very variable over the years, but it's something that we talk about every time they come into the office and review why it's important to get rid of the mucus. The reason we have to get rid of it is I feel that it contributes significantly to other complications. So the bowel is going to make mucus. Bowel is bowel, even though you've made it into an augmentation. That mucus, it can lead to incomplete emptying of the bladder. And we know that in bladder augmentation, incomplete emptying increases the risk of systemic acidosis. Incomplete emptying results in chronic overdistension and weakness of the bladder wall and may result in perforation. Incomplete emptying likely also increases the risk of UTI, as does mucus alone. Mucus and UTI together increase the risk of stones, and stones and UTI increase the risk of inflammation, and maybe all those together increase our risk of tumor formation. We don't know for certain, but it certainly seems like a good thing to prevent, and therefore mucus, irrigating mucus is worthwhile. One potential complication of augmentation, although augmentation is very good at doing what it's supposed to do, about 10% in the Indiana series would require redo augmentation. So that's why we want to be certain to bivalve the bladder widely in order to prevent an hourglass shape that will alter the dynamics. We want to be sure to reconfigure the bowel to have as spherical of a reservoir as possible and to minimize natural contractions of the bowel. If someone asks us what type of acidosis occurs after augmentation, I think everyone can quickly say hyperchloremic metabolic acidosis, but what does that actually look like? The reason it happens is that there's net absorption of acid from the urine across the bowel segment into the bloodstream. And this is related to the amount of surface area of the bowel and the amount of time that the urine is in contact with that bowel segment. So if someone catheterizes on a very regular schedule, catheterizing by the clock rather than by sensation, their dwell time is probably not significant enough in the setting of healthy kidneys to give them acidosis. So again, we want to remind them not only to irrigate, but to catheterize on a regular schedule. The kidney has to buffer whatever acid load comes, and it does that through phosphate and sulfate. With phosphate, the problem there being that if it depletes all the phosphate, then that demineralizes the bone. So the kidney also uses ammonia as that it generates to buffer the acid load. So in the distal tubule, ammonia combines with hydrogen ions and is released as ammonium back into our urinary reservoir. So what happens then with ammonium? Ammonium appears to be the primary factor actually in this hyperchloremic metabolic acidosis. So the yellow circle is our reconstructed bladder, the red is the bloodstream, and the pink blob is the kidney. And ammonium and sodium are exchanged across the port. So ammonium is absorbed into the bloodstream. Bicarb and chloride are also exchanged across the bowel lumen. So bicarb goes into the urine and chloride gets absorbed into the bloodstream. So we have net increase of ammonium chloride in the bloodstream, which then goes to the kidney. The kidney has to use its buffering system and it releases ammonium back into the bladder where things start all over again. So it's kind of a constant cycle of acid production and cleanup. And that's why it's important to get that ammonium out in the urine on a periodic basis. So we just talked about the metabolic acidosis as one of the metabolic concerns. And there was a series from Dallas a number of years ago that was not able to demonstrate any consistent acidosis. I found that the patients that I get most concerned about are those who come in with renal disease, who come in with a pre-existing acidosis. We really have to watch for them. And those may be patients who ultimately are going to have a kidney transplant, which hopefully solves that issue for them, but we need to be mindful of what to expect after augmentation. Oral agents, bicarbonate and Bicitra are helpful to protect the bones and growth in these individuals. The other metabolic concern would be B12 deficiency and the associated complications. The first paper out of Riley showed that the B12 levels were seen to decrease in time, and recommendation at that time was to screen every 5 years. We found here that just combining it with our routine labs beginning at a year is the best way for us to remember, and actually have found a fair number of people who are deficient or borderline in B12, which it corrects with oral agents in our experience, so likely is more of a baseline issue for these people than related to intestinal absorption. So B12 metabolism is good to know a little bit about. There's a substance called R-binder that's in the salivary fluid, and B12 comes from the diet. It is not present in a plant-based diet, and so those who take a plant-based diet need to take a B12 supplement because our only way to get B12 is from the diet. It's going to go down into the stomach. and will be released from the R binder as it goes into the duodenum. Intrinsic factor, which is this purple structure, is made in the stomach. So if someone has a gastric disease and doesn't make intrinsic factor, the binding that needs to happen in the small intestine between B12 and intrinsic factor isn't going to happen. And it's that binding that allows B12 to be absorbed through the small intestine. So having lack of absorptive surface or having a gastric condition that results in a deficiency of intrinsic factor can lead to B12 deficiency. If you have B12 deficiency, the concerns would be an impact on red blood cell growth or megaloblastic anemia, or formerly called pernicious anemia, impact on nerve function, which is important to our patients. And you may say, well, gosh, they already have decreased function of their legs, but this can affect their arms as well. And some of our patients actually have decent distal nerve function, so we don't need any additional peripheral neuropathy. B12 is also involved in DNA synthesis. So you can take this as an oral supplement and do follow-up labs. Depending upon the mechanism of their deficit, they may need additional treatments by injection. In terms of stones, they've been shown to occur in about 10% of cases, and about nearly half will recur. Clearing the mucus with daily irrigation of the bladder is a very good prevention, probably the best prevention. And consideration can be given as to whether they may have recurrent stone-forming organisms and whether gentamicin installations may be helpful. Spontaneous perforation, as I mentioned, used to be the most dreadful complication to talk about, and it is quite serious for these patients. It's demonstrated in almost 10% of patients. It's really important, as I said, to have a strict catheterization schedule, cathing by the clock rather than by any perceived fullness, and to perform daily irrigation to get the mucus out that may result in incomplete emptying. Adolescents and teens are kind of the poster children for bladder perforation. That's because they're invincible, or they may be involved in more difficult social situations that results in non-compliance with catheterization. This series showed that sigmoid augmentation and bladder outlet repair increased the risk of perforation, likely due to a higher tone within the bladder, but that a catheterizable channel was protective because patients are more likely to adhere to a catheterization program. And exploration is advised unless there's a suggestion that it's a very minor perforation. Exploration and externalization of the shunt if present. This is a very important paper from Dr. Fussman, who's very smart about lots of things. And this just looked at long-term complications in adults with augmentation. And he basically demonstrated that irrigating with 240 milliliters, which is quite a lot, of irrigation daily significantly reduced the risk of bladder stones and symptomatic UTIs. Of those who had who irrigated and had recalcitrant stone disease, they were not helped by metabolic therapy or by mucolytic agents. One thing I think that's very important he found in this paper, and important for us to remember about our teen patients, is that alcohol abuse in these individuals, as well as CIC noncompliance, were related to bladder perforation. And the rationale, obviously, for this is that there's an increase in the amount of urine that would be made, and likely decreased compliance with self-care, but also decreased awareness of need to catheterize, and that this would increase our risk of perforation. So I think it is important as we have teens and emerging adults, maybe those who are going off to live on their own or going to college, that we talk to them about adult beverages and what impact that may have on their urinary situation. In terms of tumors, this became the dreaded one, and this actually happened after I left fellowship, but I think everyone really paused for a long time in terms of thinking about whether bladder augmentation was the right thing to do, particularly if it was being done for continence. And as more information came along, not only was it transitional cell carcinoma affecting a ileal augmentation or a colonic augmentation, but also metastatic adenocarcinoma after gastrocystoplasty. And at that time, surveillance was recommended at the 5 to 10 year mark. This very important work also came out of Mayo, and I think this gives us the best data we have in order to counsel our patients. This looked at patients who had neurogenic bladder, exstrophy, and valves, all of whom were on clean intermittent catheterization for a large part of their life, but a subset of whom also had bladder augmentation. And for those who had CIC and augmentation, the risk of tumor occurrence was 4.6% versus 2.6% in those who were only on CIC, and this not being a statistically significant difference. So although this is not a pleasant complication to think about, and although it's something that we absolutely have to talk to families about, this was somewhat reassuring. Those who appear to be at the highest risk are those who are on immunosuppression for a transplant. So that would be likely our valve patient, but maybe some of our neurogenic patients with a 15% risk of tumor, a 1.5% risk per decade for bowel, and 2.8% decade risk for stomach. So when you think about all these things that could potentially go wrong, why in the world would you ever perform a bladder augmentation? And that's because some people actually need it, and some people want it for their quality of life, and augmentation works. This is actually the same patient in both of these pictures. You can see here that the bladder neck is open, the bladder looks terrible and trabeculated, and we have significant high-grade reflux. And after augmentation only, no reimplantation and no bladder neck procedure, you can see that the bladder neck is closed. This is the augmentation patch. So it's nicely expanded, and therefore this is the junction between the augment and native bladder. And this would be the mesentery of a continent channel or augment coming in. So we're gonna wrap up, and then I can take any questions, but I have a few parting words for you, because it's my prerogative. If you, I always like to think of, I think of all the things that I've learned from various people over the years and how sometimes I still hear their voice in my head. And I hope that you're hearing those things from your attendings. And maybe if you hear some things from me today that you'll remember forever, then I've done something else. So just because you can doesn't mean you should. And what I mean by that is we need to be mindful. Just because we have the tools to do these reconstructions doesn't mean that everyone needs one. And it doesn't mean that you need to have everything, an aug and an outlet and a continent channel and a mace. They need to have what they need. And so spending the time to get to know the dynamic and get to know what the family wants and what they can handle, and then you making sure that they understand what they're getting, we've chosen the right operation. Not too much and not too little for that patient, because we don't want to come back either. And whatever happens after you've done it, you have to own it. You need to stick with this patient throughout and take care of whatever issues they have. We talked before, that's very a time-consuming endeavor. It's a long-term relationship before, during, and after the procedure. But by the end of the day, with everything that's happened, every single thing that happens matters for these patients. And if it isn't right in the operating room, it isn't going to be right later. So you need to take down whatever the problem is and address it. And despite all of these things that sound terrible that I've told you, just try to be calm, keep your head, you know what to do, and take care of the patients. And try to do the best you can. Thank you. So I'm going to stop sharing, and I'm going to go to the Q&As. Hi, Yi. Let's see. Neha says, I was taught in the adult world to not reconstitute the bowel until you were auged, channeled, in case you need more. Do you always do the anastomosis as you go rather than waiting until you're done? Yes, as long as I have taken that extra step to make sure that that I know what's going to happen with the channel. So if it's going to be, if I think it's going to be a mitrophanol, then I need to take care of mobilizing the appendix. I need to take it off of the cecum. I need to tie off the cecum. I need to mobilize the mesentery, the appendix. I need to cut the tip of the appendix, and I need to see where it's going to reach. You can't just look at it and know what's going to happen. And so you will have made you will have harvested your appendix before you're doing your bowel work, because you need to know if you're going to take tissue from Monty. Now, you could harvest the entire bowel segment, taking some extra if you're not sure, but in that scenario, then you can't detubularize the bowel segment in preparation for aug. You need to wait until you've determined whether a Monty is needed. So you still have the opportunity to take that small piece for the Monty off of the bigger mesentery. But no, I don't wait to reconstitute the bowel until I've completed the bowel to aug. Javier from Mexico, in the case of a patient with ERD, end-stage renal disease, who needs a transplant and bladder augmentation, I'm not sure that you have you retype your question. Do I do first the augmentation and then the reimplant, or are you asking if I do them at the same time? Can you type the question again? And then Jenny, data. In the augmentation, you used first the mitrophanol. So I guess you're asking, again, kind of similar to what Neha asked about the relative timing of each. And again, you kind of flip back and forth between the two. So you have to decide first, are you going to be able to do a mitrophanol or do you need the Monty? Then you do all of the bowel work. Then I would open the bladder and make the tunnel first for the mitrophanol down the back wall of the bladder, and then put the posterior aspect of the bowel patch on. Then make sure you have your suprapubic tube, and then close the front wall of the bladder. I don't know if Javier was able to type the question again. I'm just, oh wait, let's see if there's more. So maybe it's coming. Do you put a drain around the neobladder, and how much time do you keep the suprapubic catheter and mitrophanol catheter in place before starting CIC? Okay, so if I do a bladder neck, I put a drain. If I don't do a bladder neck, I've tried to move away from doing a drain because usually I have the suprapubic tube or a Foley if they're not getting a channel, or I have a suprapubic tube and a catheter down the continent channel. So if there's no concern with the surgery in terms of how the augmentation came together, and if I didn't do a bladder neck, then I don't leave a drain anymore. As far as how long for the suprapubic catheter, if it's a mitrophanol, I leave that in for 3 weeks. If it's a Monty, I leave it for at least 4, but sometimes a little longer before I would let them start catheterizing. And then the suprapubic tube usually stays for a week after that as a safety valve. Occasionally, if I've had to leave the Monty catheter in a little bit longer, and if the patient doesn't have a bladder neck, so has that as a place where they could catheterize, then sometimes I'll take out the suprapubic tube at the same time as they learn to cath. But if they have a bladder neck, the suprapubic tube is really our safety valve, and so that stays an extra week until they've learned to catheterize. Jenny asked, sorry, I'm getting lots of distractions here on the screen. Jenny asked if you continue oxybutynin in these patients after augmentation, and I think people do that very differently. I personally keep them on it for several months because I think it helps those who are sensate be more comfortable, and I think it therefore allows their bladder patch to expand better. So yes, I do. I have a bit of a difficult time for each patient deciding exactly when I would stop it, but my goal is for them to come off of it eventually. So they come off within 6 months. Sergio, how often do you only do a bladder augmentation without a bladder neck reconstruction? I think it's a really, every patient's different. And I think you have to really look at their anatomy, look at their leak point, look at what the bladder neck looks like, look at the bladder capacity. So yes, there are times where, I think you could go both ways. There are times where I would do a bladder augmentation without any bladder neck reconstruction, because those who have a really strong external sphincter, like a fibrotic or tight external sphincter, are not going to leak. And the people who get into trouble, and need bladder augmentation due to pressures don't usually need a bladder neck reconstruction. And that's not 100%, but that's a general rule. And I would tend to give them a try without a bladder neck reconstruction. In terms of whether we would do bladder neck reconstruction without aug, I know that's a very contentious issue over the past decade in our specialty. And I think even if you very carefully select the best candidates, somewhere between a third and half will need to have an augmentation later, even if you keep them on anticholinergics. But for some families, that's worth the risk if you think that they're reliable enough to make the move later. When do you do POP? When in the post-op period do you first do mechanical irrigation? We start it from the first day, starting with 30 to 45 cc's to make sure we're clearing blood clots. And then I answered the question that was also about how long to maintain the catheters. At least 3 weeks for mitrophanol, 4+ for a Monty, and the suprapubic tube stays after. Katie asked, since the rate of the bladder augment carcinoma, since the rate of bladder augment carcinoma is much higher in persons with a transplant, do you follow these patients differently than other patients? For example, yearly cystoscopy after 10 years. I think that that's prudent. And I think in our adult patients, particularly if there's any hematuria or new abdominal or pelvic pain, recurrent infections, changes on ultrasound, any of them could have a tumor, and it's not wrong to do surveillance annually in those older patients, but certainly making them aware of the problematic symptoms. But I think it's very reasonable in a transplant patient to have extra surveillance. What irrigation do I use to clean the augmentation? We use saline. You can use sterile water, but I usually have families make saline at home, have them boil tap water and then add salt to it because it's clean. It's not really sterile in terms of the irrigation. So Javier came back with the answer to the question about transplant. Do you do the augmentation at the same time or at different times? I personally have not done any augmentations and transplants at the same time. And I have patients that have been both scenarios where they got their transplant first before, there would be special scenarios like someone who perhaps was diverted by a vesicostomy. They've been transplanted first, and then we come back and do the augmentation when they have better kidney function and are just generally healthier. But if someone has a bad bladder, I would do the augmentation first, and then they would come back and have their transplant. Ali asked, this is a good question, would you start laparoscopically and dissect the appendix and then convert? What's your opinion regarding robotic augmentation? As it was in my disclosure, I am a moderately to maximally invasive surgeon, but we have had some experience with continent channels robotically. And with a few robotic augmentations, and pertinent to your first question, I think for a patient where you're not going to do the whole thing minimally invasively, you could, because they have, I mentioned they have the high cecum and high appendix, you could start laparoscopically, mobilize the cecum, and thereby mobilize the appendix closer to the pelvis. And then you could go in through a much smaller incision to do the continent channel and augmentation, or just do the continent channel. So if you weren't inspired to do the whole channel robotically, that would be a nice combo. And we did that actually fairly frequently before we started doing robotic channels. So I think there's some fine points about robotic channels that are really different from doing it open, in that I think it's very hard to tell about tension. And we found that when we do robotic channels, implanting them down the front wall of the bladder as opposed to the back wall of the bladder seems to be more favorable in terms of reaching the skin, and also in terms of catheterizing. In terms of robotic augmentation, we did 4 and haven't done any more, and it's been a number of years. It's been more than 5 years, probably closer to 8 years since we did our last one. I just was not a big fan, but that might be my problem. Why do I prefer ilium instead of sigmoid colon? It's there, and I think we're just most familiar working with it. That said, though, if somebody had a very redundant sigmoid colon that was just sitting there right behind the bladder, I think it would be reasonable to consider using the sigmoid colon, but it does have more of a little more tone and a little more natural contraction, and so you have to be certain that you're detuberizing and reconfiguring it adequately, and it doesn't, in my opinion, doesn't reconfigure as nicely. Carmen asked if I utilize stoma and wound nursing staff before surgery for stomal markings and pre-op counseling. I don't, because there's not going to be an appliance, and because I don't necessarily get a lot of choices. I think the most important thing is to put it where it's going to work. And so you really can't determine that until intraoperatively, but I do have a good look at the patient myself in the clinic, both laying down and sitting up, and get a sense of where they can hit, like what their dexterity is. If they put their pinch your fingers together, can they go for the umbilicus? If they're right-handed, can they go for the right lower quadrant? And how low can they go? So I have a sense of where it could go, and you also want to look at where their VP shunt scar is. Do I do bladder neck closures? Yes, we do. In patients who've either have a very abnormal bladder neck, maybe someone who had bilateral ectopic ureters with no formation of the bladder neck or trigone, or other like maybe complex coaxial situations. We do bladder neck closures in some scenarios, and that quote unquote closes the door forever, but for the right patient, it's a reasonable thing to do if they desire continence. It just emphasizes how important your continent channel is. So I can't say that we've necessarily done any as a salvage procedure for failed outlet procedures in spina bifida, more for potentially some extra-fee patients, as I said, some really complex cloaca patients who may have had a very abnormal bladder neck, or someone on a kind of a similar spectrum to that, but also with ectopic ureter and just an abnormal bladder floor. I do not personally have any experience with mucosectomy and ileocystoplasty. And what procedure do you prefer in the bladder, neck, outlet, and why? We've worked really hard on that here at Lurie over the past while. Time flies, I guess. I'm gonna say 6, 7 years. And we use the modified Mitchell urethral lengthening procedure, where you essentially create a plate. You leave a plate of the proximal posterior urethra or cranial aspect of the posterior urethra and bring that onto the trigone and tubularize that strip full thickness. And then we use a sling in addition to that. So it's a bladder neck reconstruction or urethral lengthening plus sling. And we've been very pleased with the results. It's possible that it's actually obliterating the bladder neck in some of these patients. And so again, emphasizes how important your continent channel is in educating families about that. Getting close. Have you noticed a decrease in the number of bladder augmentations in recent years? No. If anything, I don't know if I was trying to exercise, all other options with families before considering augmentation, but I feel like in the past several years, if anything, I've had more bladder augmentations. And I think there is such a thing as waiting too long. I don't think, I think there is such a thing as going too soon, but I also think that if you deny the need for bladder augmentation, despite all the signs, you're not doing that patient any favors. You could be hurting their kidneys. And ultrasound doesn't always tell the whole story. So they could have significant damage that you don't recognize. And I guess one other point to make is that one question you always want to ask the particularly teens, adolescents and teens, is do they feel pressure in their flank when they're full, and is it relieved by catheterization? I found that out just incidentally in several patients, and I think I could have picked up on a problem that they had a number of years sooner. Has Botox utilization affected your threshold for proceeding with augmentation? Again, I think we also have looked at that. We're about to submit it for publication. I think that Botox, when families aren't ready for augmentation and you're trying to convince them that this is the right thing for them, Botox can buy some time. One, you can see if it works, and I think it does work, at least for a period of time. The question is whether it works enough and whether the burden of coming in for repeat injections is worthwhile. But I think it can defer augmentation safely in a set of patients until you and the family can get on the same page and fully understand. Do you recommend to parents to irrigate daily at home after discharge, and for how long? So I have them irrigate starting in the hospital twice a day, and we teach the families before they go home. We do it twice a day for several weeks, and then daily thereafter is recommended. And again, I don't know that everyone actually does it, but I talk to them about it every time they come in, and then we do that indefinitely. One more question is, what do you think about ureterocystoplasty? I think if you have a situation where you have a dilated ureter, there's some literature to support this. If you have a dilated ureter that isn't refluxing, then that would increase your bladder capacity. And we know that dilated ureters are reasonably stretchy. So that could increase your bladder capacity and potentially lower your bladder pressures. But if it is a refluxing system, so an abnormal bladder associated with a refluxing system, even if you get it all, you don't necessarily gain much, because the bladder and the ureter have been one unit anyway, so they're one pressure system already. So I'm not saying that you should throw that resource away, but I don't think that you should count on that as being a definitive answer. Do you use mechanical suture? I don't know if you mean, do I use staples? I don't use staples. I don't know if it's a mechanical suturing device. I use absorbable suture. I use Vicryl on the bladder. I use PDS on channels. I use silk when sewing the bowel anastomosis, but everything else is absorbable, but it's all just hand sewn. For sling, fascia, or SIS, each of us does it a little bit differently here. I like to do something I learned from Tony Sciaviano, which is taking a longitudinal strip of the fascia. So I usually harvest it on the left just because that's normal for me. Centimeter to 1.5 centimeters wide strip that goes all the way down to the bottom. At the bottom, I let it flare out kind of near the pubis where things get a little weaker, but I leave it intact there. And then I bring it under the dissected and reconstructed bladder outlet, tack it to the contralateral fascia, and then bring it back across and sew it to the ipsilateral fascia. So it's it's not a circumferential wrap, but it's kind of a, that's not a lasso either, but it's sutured and wrapped back across. And you can actually visibly watch how you tension the bladder neck when you pull up on it. Earl Chang, one of my associates, does an SIS sling. So it's not attached on its own. It needs to come up through the fascia and be tied over the top. Read the last question. Let's see. I think that was the mechanical. Oh, do I use mechanical sutures for closure of the intestine? So no, I don't use staples, which to me is what mechanical sutures would be. And there's no reason why you can't. I think it's perfectly safe to do that. I just think that it's good for me to teach people how to sew a bowel anastomosis because I think it's a good skill to have. So I will continue to do that. But again, there's nothing wrong with doing staples. And some may argue that it's faster, but anyway. All right. I imagine that everybody would like to go home and have dinner. So thank you very much for tuning in. I hope I answered all of your questions and everybody have a great night. Thank you. Bye.